Beginning of the season, I am Dr. Vijay Bharat. I'm an allergist and clinical immunologist practicing for last more than 25 years in Pune. And already we discussed about the basics of allergy, then allergic rhinitis as a central part in management of allergy. Then Dr. Vishal Nivara talked on allergic conjunctivitis, how it is a localized effects of a systemic disease, and about the atopic march also, from atopic dermatitis to asthma, or childhood asthma to atopic dermatitis, sinusitis, or vernal keratoconjunctivitis conjunctivitis. So how allergies I mean, connected all this way. And now today we'll talk a very common problem like asthma. Still, people don't know that 90% of the children have underlying allergy. In adults, also 65 to 80%, when we do the allergy test in adult asthmatics, the skin prick tests show the positivity compared with the positive histamine. And what are the recent advances in managing these patients? Like till now, we talked about the standardized allergy tests also, but we'll see now how in 2023 afterwards, what the GINA also says and how we can manage the asthma patient in our day-to-day practice. Even low and middle income countries, 96% of the asthma deaths and 84% of the disability adjusted life years were low and middle income countries. So recently also when I talked on asthma, I found like most of the deaths still happening in developing countries and India is one of the top mostly to that. Symptoms of asthma are similar worldwide, but patient language may differ and comorbidities may vary depending on environmental exposures as smoking, biomass fuel exposure, incidence of chronic respiratory infections from tuberculosis and HIV, AIDS. And if you see all these things, we have a lot of biomass fuel. Smoking is also there. Pollution is a big problem now in urban, like construction dust, vehicular exhaust. In rural areas, the pesticides used, and while having this pesticide spray, the diesel is used a lot in even cultivating the farms, like tractors and all. The diesel particles are there. So these are all pollutants. It is not acceptable in 2023 for clinicians to have an to manage asthma with SABAs and oral corticosteroids instead of preventive ICS containing treatment. So even nowadays, the concept is that minimum use of respiratory therapies, and instead of that, use a proper controller therapies like inhaled corticosteroids and even above 5 years. Rather than SABAs, the inhaled corticosteroids with LABAs can be used to have a very better control of this asthma above 5 years of old. If you see the this is a chart like where symptoms compatible with asthma, evaluate for alternative diagnosis, chronic obstructive lung disease, sarcoidosis, GRD. Around 40% of the children with asthma have a GRD. Adults also, many of them, because of GRD, they have a reflux, which irritates the throat and it leads like an asthma. Acute or chronic respiratory infections, sinus diseases, bronchitis, bronchitis, obliterans, interstitial lung disease, cardiovascular disease. Infants don't limit immediately as an asthma. There can be a cardiovascular problem or some congenital malformation to the lungs. Assess for asthma-associated diseases, ABPA, eosinophilic granulomatosis, aspirin sensitivities. Some of the patients, even with the beta blockers as well as the captopril inhibitors, they can have a trigger. Rhinosinusitis, exercise-induced bronchospasm. Assess for the environmental exposures and triggers. But very important. Dust, tobacco, smog. Still, people are doing the dusting at home. All these dust, molds, animals, perfumes, cold air, work environment, medications. Evaluate the medication regime, high dose ICS plus second controllers, proper medication delivery, adherence of the patient properly. See the techniques and all, how they are taking properly. Even I have found like in the rotailers, they just go on popping the rota caps, but they don't clean it properly. So check it. Two or more exacerbations in a year, phenotyping. Like nowadays, eosinophilic asthma, early onset, late onset, neutrophilic asthma, pregnancy induced. So we have to see like even menstruation cycle also may. So depending on that, if the symptoms are compatible with asthma, spirometry evaluation or even oscillometry is and you can go for the phenotypes. Pulmonary function test, if required, then ECG test, then empirical treatment with proton pump inhibitors if GRD is there. Then if any or the other like asthma associated diseases, then total IgE levels as a monitoring. But standardized skin test is very useful as a, for the allergen. an ANCA CPC count with the eosinophil count. Environmental exposures, always avoid the exposures. Evaluate medical proper inhaler techniques and all. And if phenotyping, then eosinophil count, serum total Ig, interleukins, mast cells and all. And then depending on that, targeted asthma therapies can be given these patients. If you see the endotypes and phenotypes, asthma risk factors are genetic variants and environmental exposures, lifestyle, sleep, obstetric sleep apneas, comorbidities, endotypes, immune responses and memories, transcriptome, inexpressions, metabolome, proteome. And asthma phenotypes, elevated Ig, Th2 inflammation, microbiome, eosinophilia, bronchodilator responsiveness, increased BMI. Obesity is also a very important cofactor. Comorbid diseases are common in patients with asthma and can substantially worsen the asthma symptoms, specifically rhinosinusitis, rhinoconjunctivitis, vestibular tube problems, throat, Th2 inflammation, tonsillar adenoids, secondary infections. Allergic rhinitis is present over one half of children with asthma. It present at an increased frequency in both adults and children. So even asthma, out of 82% have a allergic rhinitis. And even non-smoker adults with severe asthma in one cohort it was shown. Allergic sensitization also frequently co-occurs with asthma, particularly in children. Obesity has an inverse relationship with lung residual volume, which can exacerbate dyspnea symptoms in individuals with asthma. However, inflammatory states in the lung and of lung immune cells and adipose tissue are also altered in subjects who are obese, including increased levels of the pro-inflammatory molecules like IL-6, leptin, tumor necrosis factor alpha. The presence of snoring should also be considered in patients with asthma. GERD is also a common condition, contributes to worsen symptoms in both adults and children. In adults who have smoked, asthma and COPD can coexist, has been described as an asthma COPD overlap syndrome. Not only smoking, even in India, the pollution is a big problem. Western world, the smoking is. What allergy test in asthma? The presence of atopy increases the probability that a patient with the respiratory symptoms has allergic asthma. Not specific for asthma or it is present in all asthma phenotypes. Atopic status can be identified by skin prick test or by measuring the level of specific Ig as a immunocap or even advanced component resolved diagnosis. Environmental allergens skin prick test is the gold standard. It's simple, rapid to perform when performed by an experienced tester with standard extract, inexpensive and high sensitivity. Measurement of Ig serum specific, no more reliable than skin test and more expensive, but may be preferred for uncooperative patients, those with a widespread skin disease, or if the history suggests a risk of anaphylaxis and presence of a positive skin test or a positive serum Ig, however, does not mean that the allergen is causing a symptoms. So we have to always have a clinical correlation after the testing also. Again, clinically correlate and then document it. Before considering any step up, first confirm that the symptoms are due to asthma. Identify and address common problems such as inhaler technique, adherence, allergen exposure, and multimorbidity. Provide patient education also. Stepping down to find the minimum effective dose. Once good asthma control has been achieved and maintained for 2 to 3 months, consider stepping down gradually to find the patient's lowest treatment that controls both symptoms and exacerbations. Provide the patient with a written asthma action plan, monitor closely, and schedule a follow-up visit. Do not completely withdraw ICS unless this is needed temporarily to confirm the diagnosis of asthma, like before the pheno, oscillometries and all. For all patients with asthma, provide asthma education and training in essential skills. Give a lot of time than the prescriptions. Train the staff. Keep a lot of literatures, booklets, and all to get understand by the patients because a lot of misconceptions still, and people prefer the traditional Ayurveda homeopathic than the research-based, scientific-based, or evidence-based allopathic medicines. After choosing the right class of medication for the patient, the choice of inhaler device depends on which inhalers are available for the patient for that medication, which of these inhalers the patient can use correctly after training, and the relative environmental impact. Check inhaler technique frequently. So what relative environmental impact means? Some of the inhalers, they, whatever the CFC, they have also effect on the environment. Pollution can happen. So now even there are newer tech inhalers where the less environmental pollution will be there. Digitalized one. Provide inhaler skills training. This is essential for medications to be effective, but technique is often incorrect. Encourage adherence with controlled medication, even when symptoms are infrequent. Provide training in asthma self-management, self-monitoring of symptoms or peak expiratory flow meters, written asthma action plan, regular medical review to control symptoms and minimize the risk of exacerbations. For patients with one or more risk factors for exacerbations, prescribe ICS containing medication preferably, which has needed low dose ICS formoterol as reliever. Provide a written asthma action plan and arrange review more frequently than for the low risk patients. Identify and address modifiable risk factors, smoking, low lung function, overuse of SABA. Consider non pharmacological strategies and interventions to assist with the symptom control and risk age reduction. Smoking cessation advice, breathing exercises, some awareness strategies. These are very important. The breathing exercises are very important for this patient. Difficult to treat and severe asthma. Patients who have poor asthma control or exacerbations, despite medium or high dose ICS LABA treatment, should be assessed for contributing factors and asthma treatment optimized. If the problems continue or diagnosis is uncertain, refer to a specialist center for phenotypic assessment and consideration of add-on therapy, including biologics. Like allergists are the very well or the chase physicians which have experience in biologics and phenotypic and allergy testing and all has to be referred. For all patients, use your own professional judgment and always check local eligibility and payer criteria. Allergen immunotherapy is the only disease modifying therapy depending on the selection of the patient. Specifically, children have a very good recovery. Adults also, wherever there is a 65 to 80% patients, where the specific dust mites and pollens or animals, insect droppings, dried feather, pigeon feather droppings, and all, where we can have a very good disease modifying desensitization. So, allergen specific immunotherapy may be a treatment option where allergy plays a important role, including asthma with allergic rhinoconjunctivitis. There are currently two approaches: subcutaneous immunotherapy, sublingual immunotherapy. Even oral immunotherapy has been in USA, in India also, the research is happening. The allergens most commonly included in allergen immunotherapy been house dust mite and grass pollens. Subcutaneous immunotherapy involves the identification and use of clinically relevant allergens, administration of extracts in progressively higher doses to induce the desensitization or tolerance. European physicians tend to favor single allergen immunotherapy, whereas Northern American physicians often prescribe multiple allergens for treatment. So in India also nowadays, multiple allergens are included because looking at our so much geographic variations and so many uh, trees and pollens. In people with asthma and allergic sensitization, subcutaneous immunotherapy is associated with a reduction in symptom scores and medication requirements and improved allergen-specific and non-specific airway hyperresponsiveness. Compared with pharmacological avoidance options, potential benefits of subcutaneous immunotherapy must be weighed against the risk of adverse effects and the inconvenience and cost of the prolonged course of therapy, including the minimum half-hour wait required after each injection. So sublingual immunotherapy also 2013 it has shown as effective as compared to the subcutaneous immunotherapy. Sublingual immunotherapy, modest effects were identified in a systematic review and in even adults and children. The evidence for important outcomes such as exacerbations and quality of life remains limited. There are few studies comparing SLIT with pharmacological therapy for asthma. A trial of SLIT for house dust mite in patients with asthma and HDM allergic rhinitis demonstrated a modest reduction in ICS with high dose sleep. For adult patients with allergic rhinitis and sensitized to house dust mite with persisting asthma symptoms, despite a low to medium dose ICS containing therapy, considering adding sleep, but only if FE1 is more than 70% predicted. Because if there is a lower one, control the inflammation first, let the FE1 improve, and then only give the immunotherapies. As for any treatment, potential benefits of sleep for individual patients should be weighed against the risk of adverse effects and the cost to the patient and the health system. Even long-term wise, it has also shown very good results in Europe and in India, and people are seeing. Multimorbidity is common in patients with chronic diseases such as asthma. It is important to identify and manage multimorbidity as it contributes to impaired quality of life, increased healthcare utilization, and adverse effects of medications. In addition, comorbidities such as rhinosinusitis, obesity, GERD may be contribute to respiratory symptoms, and some contribute to poor asthma control. For patients with dyspnea or wheezing on exertion, distinguish between exercise-induced bronchoconstriction and symptoms that result from obesity or a lack of fitness or the result of alternative conditions such as inducible laryngeal obstruction. Provide advice about preventing and managing the exercise-induced bronchoconstriction. So slowly tolerance can be developed. All adolescents and adults with asthma should receive ICS containing treatment to reduce the risk of severe exacerbations. It should be taken every day or as an alternative in mild asthma or by as needed ICS formoterol for a symptom relief above 5 years of old. Even still, after so many years, we have seen that patients have misconceptions about inhalers that they are addictive and all, but it's not that way. They are very safe, targeted therapies. Still, the people's misconception of myths should be removed and the evidence-based medications should be educated to them. Refer patients with difficult to treat or severe asthma to a specialist or severe asthma service centers. What is the type 2 inflammation? So nowadays, all these asthma patients, the type 2 inflammation is very important. In majority of the people with severe asthma characterized by cytokines as the interleukin 4, 5, 13, which are often produced by the adaptive immune system on recognition of allergens. It may also be activated by the viruses, bacteria, and irritants like perfume, smoke, and tobacco that stimulate the innate immune system via production of IL-33, IL-25, and thymic stromal lipoprotein by epithelial cells. That's why nowadays, where it is a type 2 inflammation and where this TSLP is suspected, now anti-TSLP monoclonal antibodies are also there. Type 2 inflammation is often characterized by elevated eosinophils or increased FeNO, and it may be accompanied by atopy and elevated IgE, whereas non-type 2 inflammation is often characterized by increased neutrophils. In many patients with asthma, type 2 inflammation rapidly improves when ICS are taken regularly and correctly. This is classified as mild or moderate asthma. In severe asthma, type 2 inflammation may be relatively refractory to high dose ICS. It may respond to OCS, but their serious adverse effects mean that alternative treatment should be sought. In adult patients with uncontrolled asthma, despite medium or high dose ICS plus LABA or other controllers, a history of exacerbations in the previous year, higher blood eosinophil counts, and higher FeNO levels are associated with a greater risk of severe exacerbations. Could the patient have refractory or underlying type 2 inflammation? The possibility of refractory type 2 inflammation should be considered if any of the following are found while the patient is taking high dose ICS or daily OCS. Blood eosinophil counts more than 150, FeNO more than 20 ppb, total eosinophils more than 2%. Asthma is clinically allergen driven. Patients requiring maintenance OCS may also have underlying type 2 inflammation. However, biomarkers of type 2 inflammation, blood eosinophils, sputum eosinophils, or nasal eosinophils, FeNO, are often suppressed by OCS. If possible, therefore, these tests should be performed before starting OCS, a short course maintenance treatment, or at least 1 to 2 weeks after a course of OCS, or on the lowest possible of OCS dose. The above criteria are suggested for initial assessment. Those for blood eosinophils and FeNO are based on the lowest levels associated with the response to some biologics. They are not the criteria for eligibility for type 2 targeted biologic therapy, which may differ. Consider repeating blood eosinophils and FeNO up to 3 times when asthma worsens before giving OCS, or at least 1 to 2 weeks after a course of OCS, or on the lowest possible OCS dose. Before assuming asthma is non-type 2, one study of patients with uncontrolled asthma taking medium to high dose ICS LABA found that 65% had a shift in their blood eosinophil category over 48 to 56 weeks. Why is the inflammatory phenotype assessed on high dose ICS? Most RCT, randomized controlled trial evidence about type 2 targeted biologics is in such patients. Modifiable ICS treatment problems such as poor adherence and incorrect inhaler techniques are common causes of uncontrolled type 2 inflammation. Currently, the high cost of biologic therapy generally precludes their widespread clinical use in patients whose symptoms or exacerbations and type 2 biomarkers are found to respond to ICS when it is taken correctly. Nowadays, even these biologics like opalizumab, bipolizumab, bendalizumab, tezekimab, itiquimab, and all, they are covered under the insurance, most of the companies. So it's very easy also. Only thing, the acceptance by the patients is very important. Manage and monitor severe asthma treatment. Review response and implications for the treatment. So always review the response after 3 to 4 months, every 3 to 6 months for ongoing care, symptom control, questionnaires and all lung function testings, comorbidities, medications, how correctly adherence technique, patient satisfaction, any side effects, any oral treatments, oral corticosteroids and all assessed properly. Again, OCS, oral corticosteroid, should not be given because there are a lot of side effects. It has been found. So consider the other treatments. If there is no evidence of type 2 inflammation, if there is no evidence of type 2 inflammation, then exposures, irritants, additional diagnostic investigations, bronchoscopies, CT scans, add-on llamas also can be there, ECGs and all to avoid the long QTC. And if there is a neutrophilic or anti-IL-4 R4 treatments like the variants benralizumab and anti-TSLP thymostomal lipoprotein molecules like tezekimab and all can also be used against this. At a last resort, consider add-on low-dose OCS, but implement strategies such as alternate day treatment to minimize the side effects. Consider bronchial thermoplasty with registry enrollment. However, the evidence for efficacy in long-term safety is limited. Stop ineffective add-on therapies. Continue to optimize treatment, including inhaler technique, adherence, non-pharmacological strategies like environmental control diet. Even some of the patients' spicy diet or some things also can trigger the things. Like it has been found practically, milk or eggs and fish and all. So it is an intolerance. It is not a primary allergy, but avoid for some time. Treating comorbidities like rhinitis, like nasal steroids are very important in most of the patients. Then rhinosinusitis, osteoarthritis, sleep apnea, obesity, that also. Consider the non-biological options in their evidence of type 2 inflammation. For patients with elevated type 2 biomarkers, despite high dose ICS, consider non biological options. Assess adherence objectively by monitoring the prescribing and dispensing records. Suppression of high FeNO after 5 days of directly observed therapy was an indicator of past poor adherence. Consider increasing the ICS dose for 3 to 6 months. Review again, consider an add on non biological treatment for specific type 2 clinical phenotypes. For example, for aspirin exacerbated respiratory disease, consider an add on LTRA like montelukast, possibly aspirin desensitization. For allergic bronchopulmonary aspergillosis, consider add-on OCS or antifungal agent. For chronic rhinosinusitis, with or without nasal polyps, consider intensive intranasal corticosteroids, surgical advice if needed. For patients with atopic dermatitis, topical steroidal or non-steroidal therapy, moisturization also has shown a very good because the sensitization also can be there from there. So, is type 2 targeted biologic therapy available and affordable? Consider high-dose ICS-LAMA if not used. Consider other add-on therapies, LAMA, LTRA, low-dose azithromycin for 10 to 15 days depending on last resort. Consider add-on low-dose OCS but implement strategies to minimum side effect. Stop ineffective add-on therapies. Continue to optimize treatment including inhaler technique, adherence, non-pharmacological strategies in treating comorbidity. If the patient has not had a good response to any type 2 targeted therapy, stop the biological therapy, review the basics for factors contributing to symptoms, exacerbations, poor quality of routine. Treating to control symptoms and minimize future risks. Consider additional investigations. Already we discussed about those things. Stop ineffective add-on therapies, but do not completely stop the ICF. Collaborative optimization of patient care. Check the techniques again and again. For athletes specifically, we found a lot of studies we did around 450 athletics with them, leader studies and clinical features. Athletes, particularly those competing at a high level, have an increased prevalence of various respiratory conditions compared to non-athletes. They experience a higher prevalence of asthma, allergic or non-allergic rhinitis, exacerbations of bronchial asthma, chronic cough, inducible laryngeal obstruction, recurrent respiratory symptoms. Airway hyperresponsiveness is common in elite athletes, often without reported symptoms. Asthma in elite athletes is commonly characterized by less correlation between symptoms and pulmonary function, higher lung volumes and expiratory flows, less eosinophilic airway inflammation, more difficulty in controlling symptoms, and some improvement in airway dysfunction after cessation of training. Management preventative measures to avoid high exposure to air pollutants, allergens, and chlorine levels in pools, particularly during training periods, should be discussed with the athlete. Even in our pools and all, many of the people still don't go for the urination in the toilets. They just go doing into the pools. So again, that combination also can create a lot of problem. So that also has to be looked because in Pune we found a lot of urine into these swimming pools. They should avoid training in extreme cold or pollution, and the effects of any therapeutic trials of asthma medication should be documented. Adequate anti-inflammatory therapy, especially ICS, is advised. Minimization of use of beta-2 agonist will help to avoid the development of tolerance. So These newer asthma guidelines, according to the JINA also, should be implemented in severe asthma patients so that we can have a very good control line rather than labeling them as a asthma COPD overlap or some other ABPA or tuberculosis and all. Always assess because the asthma has increased because of so many factors like environmental factors and all. And coming together, we can have these steroid sparing treatments like biologics, omalizumab, mepolizumab, benralizumab, tezekimab, etikimab, and all. And we can have a very good control in asthma COPD as a LAMA introduction also. So that way we can manage these patients very well.